Good evening, everybody, and welcome to this webinar sponsored by Amgen with Emirates Cardiac Society. It's my pleasure to welcome you tonight, although today is a holiday, so I'm really happy that you're joining us today to talk about risk assessment to LDL goals and achievement of LDL goals. I have three distinguished speakers today with me. I'll introduce them at the beginning so we can get into the topics and we can learn as much as possible from all of them. I will encourage you all to post your questions in the chat so we can get to them at the end, because after all the three presentations, we're going to have a panel discussion and we're going to address all your questions. So today we have, as I said, three distinguished speakers. We're going to start with Dr. Roni Shantouf, who is an interventional cardiologist and a staff physician at the Heart and Vascular and Thoracic Institute of Cleveland Clinic, Abu Dhabi. He's also the director of the Cardiac Cath Lab and the co-director of Complex Coronary Program and the co-director of Invasive Coronary Spasm and Microvascular Dysfunction Program. So Dr. Roni is going to talk to us about Mind the Gap, optimizing dyslipidemia management. And then we're going to have our dear friend, Professor Giuseppe Rosano, who I'm sure a lot of you know him. He's a very good friend to the Emirates Cardiac Society. He's a professor of cardiology and consultant cardiologist at the St. George Hospital, NHS Trust, University of London. And he's going to talk to us about lowering LDL target to better outcomes. And then we're going to have Professor Mahmoud Abdelghani. He is a consultant interventional cardiologist at Mediclinic City Hospital, who served as an associate professor of medicine and cardiology at Cleveland Clinic, Ohio. And he will finish up by talking beyond LDL reduction with towards plaque regression. And then we're going to have our discussions. So without further delay, I'll hand it off to Dr. Roni to talk about, to present his talk. Go ahead, Dr. Roni.
Thank you, Dr. Joyra. We'll get started. All right. So we're going to get right into it, talking about minding the gap and optimizing dyslipidemia management. And hopefully this sets the tone for the rest of the talk. So I think, as usual, it's important to remind ourselves of the burden that we're fighting up against that exists globally and specifically in the Gulf region. We know that cardiovascular disease is the leading cause of death, and it amounts and is responsible for almost and greater than actually 40% of UAE deaths overall. Gulf patients experience cardiovascular events that are approximately a decade younger than our Western counterparts. And so this obviously is a huge burden, not only in terms of its totality, but the fact that it affects people a good decade prior and really in their prime years of productivity, let alone its impact on family life. When we look at the Intraheart study, we notice that there are multiple risk factors that contribute to the risk of an acute myocardial infarction, and it attributes to greater than 90% of the burden. And these are for typical things such as smoking, fruit and vegetable, lack of fruit and vegetables, lack of exercise, hypertension, diabetes, psychosocial, and lipids, which is the largest impact of all the 9 risk factors in this study. And so, one might ask, the fact that we have such a high burden, the fact that we already know that lipids have a major effect, how is the world doing when it comes to lipid management? And if we ask the question in terms of ACS patients, who might, one would think would be the easiest target in regards to LDL management. What we can see here, approximately anywhere from 30 to 50% of patients are achieving the targets based on the recommended guidelines. And this is whether or not you're going to pick a target of less than 1.8 or 1.4. You can see throughout the world, you have at best around 50% in some regions such as the United States and Australia, whereas many other places are really lacking and are much lower in regards to that. So we have a disconnect here in regards to patients achieving goals, patients being tested, which we'll talk about. LDL testing is also inadequate, and also the fact that we already know that this is the largest burden. And so the question is why and what can be done. So I think we need a little bit more statistics to get things in place, and we can see what we find is a large portion of patients in the Gulf and the Middle East just don't achieve their target lipids. And we kind of dive a little bit deeper. That's anywhere from 50 to almost 70% of patients are not achieving target guidelines. And these are based on 2004, a lot of these statistics. So you can imagine that that number would go up. If we look at the DICES-2 study, almost 76% of patients were not achieving their targets, and more than 88% of the patients with ACS were not at target. And so this is obviously a very disturbing number, and we want to kind of dive into this a little bit more. If we look at the Action Gulf Registry, secondary prevention patients not reaching the recommended target. So we can see that this theme repeats itself over and over, regardless of where we're looking at this, in what parts of the world, how many studies get done, different study groups showing the same thing. Why is this concerning? Well, we do know that the residual risk of patients after a cardiovascular event is actually the highest immediately after an MI, stroke, or death. And that's actually the highest probability is after an ACS event, putting that at the highest risk of either an MI, stroke, or death. And that's actually within the first 3 to 6 months. So you have the highest risk patients with the highest risk period, and yet we don't see the movement in regards to that therapeutic window being satisfied. Again, if we look at patients, here's another study showing similar data that the event rates are highest in patients with a prior event occurring within 1 year. And then, we remind ourselves of the data. We have multiple studies. 49 studies were done in this famous meta-analysis where we really looked at all the data that was done in terms of statin therapy and finding, what we all know, that for every millimole per liter reduction of LDL, we're receiving approximately around a 20% reduction. And so this is really part of the discussion and sets the stage. Why do we have clear data showing risk reduction? Why do we have clear data showing patients are not achieving targets? Why do we have medications that work and yet that mismatch is there? And this is not an orphan disease. This is a disease burden. This is the number one impact on folks globally and specifically in the region. So one might ask, well, is there any urgency to reach LDL targets within a certain period of time? One might say, well, we have time. We'll see them back in 6 months. We'll see them 1 year later. We'll start them on a medication. We'll bring them back. Actually, we have registry data. This is out of Sweden showing that the greater the LDL reduction was 6 to 8 weeks after a post-MI was associated with a lower risk of cardiovascular events over time. So the larger that LDL reduction is, within that 6 to 10 week period post-MI, the greater the benefit over time. So patients who had the largest absolute LDL reduction, when you compared, had a 23% decrease in MACE and a 19% decrease in MI, looking at that over time. What about lipid-lowering therapies? And just again, how have they evolved? Obviously, our targets have shifted, and a lot of patients say you keep moving the goalpost. But obviously what's happening is that we're just getting newer and newer data reinforcing the model that lowering your LDL has continued benefit with no floor that's fundamentally been identified in any of the studies. We look at the Fourier study. You actually dice up the data that the risk of major cardiovascular events was actually progressively lower with lower achieved LDL. So within that study group who already had a very low LDL achieved target, we still saw continued benefit when comparing to higher LDL endpoints. So where are the gaps? So let's kind of dive into the gaps themselves. So obviously there's suboptimal treatment for patients. And the question is, what might that lead to? Well, when we think about vulnerable, the plaque itself, 20% of ACS survivors experience a subsequent ischemic cardiovascular event within 24 months. That is very high. 1 in 5 patients that we're going to see, that we're going to take care of this week, who's going to have an MI this week, and we are going to be their cardiologist, 1 in 5 of them are going to come back within 2 years. And the question is, which one of those is going to be the patient that's most likely to come back? And did we do everything we can to, first of all, educate patients in regards to everything that they can do to lower their risk? And that's always the fundamental question. We look at failure of LDL target achievement. 75% of secondary prevention patients did not achieve recommended LDL goals. 75. We looked at suboptimal LDL testing. 73% of patients hospitalized for their first MI did not even have a lipid test within 90 days following discharge. We have data showing that within 6 to 10 weeks of getting under control showed benefit for the long term. We have data showing that the lower your LDL post-event, the lower your risk. Yet, 3/4 of patients do not even get a test within 90 days after being discharged, probably because they're not even being seen by a cardiologist for 90 days at that point. So questions for us to consider regarding our management is, what is the lipid management protocol for ACS at your own hospital? What is the percentage of LDL target achievement that you have at your own hospital for patients that have a recent MI? And how frequent are we testing? So these are things that you might want to look into in your own institution to really sort of think about that. And this just, again, hammering the point that 1 in 5 patients who've had an MI will come back within another event within 1 to 2 years. And again, just showing that the recurrent events are still high in the first year post MI, especially for those first few months. So I'll skip this slide. We discussed this regarding all of this. So what happened? So we already know that testing is very low and that most patients don't achieve event. But let's look at the data a little bit closer. We actually find that 22% of patients achieved LDL levels of less than 50 within the first year. And so you can see, and it's probably that same group of patients. You can't tell exactly from this data, but you see that 20% line is flat. It's likely whoever got treated and got put to target just remained at target. You probably had minimal wiggle room if you missed that window of opportunity to really get their LDL at goal. And again, looking at similar studies showing similar patterns, that we see that LDL testing rates will slightly go up, but even out to a year, you only have 50% of patients getting LDL tested. And even worse, that only 20% of patients had one LDL testing or lipid testing within the first 2 years. We can see over here in a panel. So our guidelines are moving towards lower and lower LDL, yet are achieving those targets despite having therapeutic options remains a major gap. So I think with this, let's kind of shift over and start to talk a little bit about the guidelines. We'll sort of highlight some of the major aspects that I find important for us to consider. And we'll use that as a stepping board really for the following talks. So when we think about cardiovascular risk categories, first of all, it's very important that we decide on where we are and which guidelines that we're using, because there are some slight differences looking at the guidelines themselves. But they all undergo fundamentally similar aspects where you're risk classifying patients into different risk categories. And based on that category, there's an established target. And if the patient falls out of the category or it's unclear where that category is, there are other metrics that fall outside of the usual method of risk stratification, that these will be risk enhancers that will help you to reclassify patients overall. And so if we look at some key things about patients, if we're looking at the ESC guidelines, what's very simple to consider is patients who are very high risk are patients with established disease. So very simply put, if a patient has established ASCVD, either clinical or unequivocally on imaging, then they're essentially would fall under the category of ASCVD. These are patients who have had an acute MI prior. They can have chronic coronary syndrome. They've had prior revascularization, stroke, TIA, or significant peripheral artery disease. So anybody that falls under having some sort of atherosclerotic burden that's felt to be unequivocal, and by clinical, we define it as unequivocal. And on imaging, there's going to be some variability depending on what guidelines that you use. I would argue that if you have a significant amount of plaque, especially at a younger age, that to me is unequivocally ASCVD and should be treated as such. There are calcium score cutoffs that are starting to show itself in these guidelines, although I think we have to be wary a little bit about them, because what I think the guidelines don't do, at least in the slides and the tables, is really factor in one's age in regards to that. There is now a little bit of a push to thinking about where they are in the scale for their age. So if you're in the higher percentile, then that's an increased risk, and we welcome that into the guidelines themselves. Other things to consider. So patients who have severe CKD are also going to be in the very high risk category. So again, so these are core aspects: defined ASCVD or severe CKD. Now, if they don't have either of those, that's where you want to risk categorize patients, and you want to do a risk calculator to define their risk estimate based on the risk calculator. And in the ESC, they're going to recommend the SCORE2 or the SCORE2 OP, or SCORE2 DM, depending on where that fits in. And that risk calculator, if they get put into the highest risk group that's greater than 20% for their 10-year risk of a fatal or non-fatal cardiovascular event, that would be a patient that will categorize as very high risk. And then lastly, patients who have familial hyperlipidemia with ASCVD or with another major risk factor. And I think what's key here is it's not so much the ASCVD, because that would fall automatically in there, but FH with another risk factor really puts you in that very high risk category. Otherwise, if it's purely FH, you'll drop down a risk down to the high risk. If your CKD status is not as bad, you'll go into that category. If you have high risk lipid or blood pressure parameters, you'll fall into the high risk category. And if you have diabetes without target organ damage, you'd fall into the high risk category, or you have a long duration of diabetes with additional risk factors. Patients who have diabetes with target organ damage or multiple risk factors, or they've had long-standing diabetes, would fall into the very high risk category, with the idea that these patients already have plaque burden buildup or at extremely high risk for rapid plaque buildup. Again, the SCORE calculator comes in if you don't meet the clinical criteria. That's where one would want to put that in. Again, one of my favorite slides is looking at this. Once you've established yourself where you are, this is where I think things start to make sense. And what I usually like to do is simply ask myself, does the patient have ASCVD? Yes or no? Figure out if they have ASCVD. That's usually not that difficult based on their clinical history. And if you have enough imaging already in your armamentum, you can answer that question. If they have ASCVD, by default, they are at least very high risk, if not extreme risk, if they've had multiple events within a short period of time. If they're very high risk, their target is going to be less than 1.4 millimoles per liter. If they don't have ASCVD, then I usually ask myself the question, do they have severe CKD, or are they a diabetic with either target organ damage or multiple risk factors that would fit us in that category? If they don't meet criteria for that, this is really where the risk scoring comes in to help to categorize the patients. And with that starting point, you can move yourself down or up. I find that's easier mentally to think about, as opposed to starting in the low risk category and trying to figure out where your patient lies. I find really kind of moving right into the very high risk, determining are they in that category, and either downgrading them or upgrading them based on this simple algorithm, or whether or not they have different risk enhancers if nothing fits into this. And so let's talk about some of these risk enhancers or risk modifiers, depending on how you want to, which guidelines you're going to reference. But some key ones is going to be family history of premature cardiovascular disease. I find this is very important. It's not part of the risk calculators, but this is critical for these patients. Patients with high risk ethnicity, such as Southern Asian, is an extremely high risk category and actually gives you a significant increased risk. And there are papers on this talking about what that differential is and how much that changes. Other issues are going to be severe stress symptoms, social depravity, obesity, physical inactivity, any immune-mediated inflammatory disorder, any major psychiatric disorders, premature menopause, preeclampsia, or other hypertensive disorders, HIV, obstructive sleep apnea, and some key biomarkers are going to be elevated CRP, high sensitivity CRP greater than 2, or an elevated lipoprotein A greater than 105 nanomoles per liter, are really going to use that to reclassify patients. And I think these are very critical in helping patients, especially patients who don't have established disease or established major risk factors. And so, again, if you can read through all these steps, and it's very helpful, but I find that if you start with that slide that really helps to categorize patients and kind of move them up and down in a more simplistic fashion to help guide you through the guidelines itself. Now, you've established that the patient needs therapy, and we want to look at how the guidelines have changed and what they're discussing. So, verbatim from the guidelines, non-statin therapies with proven cardiovascular benefit, taken alone or in combination, are recommended for patients who are unable to take statin therapy to lower LDL levels and reduce the risk of cardiovascular event. The choice should be based on the magnitude of additional LDL lowering needed. So I find this is actually very interesting how they've approached these guidelines, where the updates, where they have defined it as unable to take statin therapy, and of course that opens it up for a lot of conversation, actually, in regards to how do you define unable regarding that. And the aspect of proven cardiovascular benefit and combination becomes very important here when talking about this, and really looking at the magnitude of LDL reduction. It is very easy. You can get a slide, you can look online in regards to how to think about it. So if a patient really has an LDL of 4 or 5, and you need to get them to target of at least, let's say, 1.8 or 1.4, you have a long way to go. We already know that statin therapy is going to give you anywhere from, let's say, 30 to 40+% of LDL reduction. By default, you're not going to achieve the target. You need to already start to think about that second medication, potentially that third medicine. And I actually start that conversation with the patients at the very, very beginning. Now, one, of course, approach is to shotgun and put them on maximum, combined therapy. I find that has pluses and minuses, and I find it depends on, and I will do that depending on patient's clinical scenario. If they have stable chronic disease or it's primary prevention, I may not want to take a shotgun approach with the highest doses, because I don't want the patients to come back with side effects or any presumed side effects, and then really we lose our opportunity of therapy or that relationship building to help to build up the medications. So that might be one where I'll sort of move my way up, but I'll start that conversation early, saying, look, you're over here. This is your target. This is where we're going to need to go. So we're going to start this. We'll bring you back in a month. And at a month, we'll recheck the labs. Now, I think it's critical that this gets done on a monthly basis, 4 to 6 weeks maximum, because that's when you have your audience. That's when you have the patients listening, and you can bring them in and get them to goal. There is no reason, if you've already established a patient needs to be at a specific target, to spend 1 year, 2 years moving them to that target is really a loss of opportunity for the patient to get really the best benefit they're going to get from the medication. You've already committed these patients to therapy. The patients are already willing to take therapy. They already agree to take therapy. And so to take your time to get them at goal really, I think, defeats the purpose. So now here's a slide really looking at the combination, and we can see that when you start to do a dual or triple therapeutic combinations, you really can get anywhere from 80 to 85% reduction, sometimes higher, depending on how they respond to specific medicines. And so looking at high intensity statin plus a PCSK9 monoclonal antibodies really is going to give you your best sort of combination regarding that. Now, what are the AHA or ACC guidelines? What does the US counterparts look at? So I actually find the European one slightly less sort of confusing, but I find we welcome that the updates that are there in regards to that. And so there are different ancillary risk markers that do get discussed, such as checking ApoB, which I do find helpful if you have patients who are you're really worried about them and you really want to make sure that they are at the lowest risk category that they can be, and you really want to make sure that LDL is down and that ApoB is down also, and not just one. Sometimes you get that discordance between the two, where the cholesterol content might be low, but the actual number of particles that are floating around are still going to be high. And so using that to help you, I think screening lipoprotein A is absolutely critical. nowadays. It's very important to define these patients and categorize these risks. And for me, it's absolutely critical to measure these. I measure these in all my patients, especially with therapeutic options coming. I think it's important that we start to really identify patients that would be potential, patients for therapy. Not only that, you really start that discussion regarding not just lipoprotein A therapy, but also the other risk factors that they do have. So our targets have moved down overall. With the update, we really do see that patients at the higher risk category are really looking at an LDL now of less than 1.4, whereas that number used to be higher at 70. And we see that these guidelines are starting to move a little bit on the same page. They have really sort of broken up subclinical atherosclerosis regarding coronary calcium and sort of defined it into multiple categories, which I think is reasonable. I think what's most important is really start that discussion, really let patients identify, look, you have plaque, and now we need to do something about it. And I think the percentile is helpful because it really looks at age, gender, and race as part of the process, and using that to sort of help define where they'd fall on the risk. They have changed the risk calculator to the Prevent ASCVD risk calculator. I'll really, leave it to the rest of the team to talk about. I have not fully incorporated it into my routine thinking. I'm still sort of heavily weighted towards the SCAR2 and MESA calculators, depending on if we have imaging to help me. They just really kind of highlight the importance of individualized benefit risk discussion. I think that's been there from the beginning. I don't think we need to belabor that. It's absolutely critical. Risk enhancers are going to be very similar, looking at the same thing with slightly different cutoffs, but overall, looking at the same risk factors in regards to what might to contribute patients and really bump patients up or reduce their risk when thinking about it. So I think for the sake of time, I'm just going to move through some of these guidelines, to take a look at it. It's sort of a similar process. I'm sure this will come up in some of the other talks that we'll see here. And so one of the main things is really looking at how we define very high risk, whether it's patients who have had a major ASCVD event or they have major risk factors to put them at the high risk category. And how we should approach these patients with secondary prevention. I think what becomes important is thinking about getting the patients to goal. And to me, the overarching thing, again, is the same theme. Use whatever risk sort of scoring system and category you want to use, whether it's ACC, AHA, or the European guidelines. Use them, set a framework, establish a target with your patient, open up that discussion around the target and why you should be at that target, discussing whether you're going to look at imaging, you're going to talk about IVUS studies, OCT studies, you're going to talk about the clinical endpoints. All these things become actually critical. And you have that conversation around target, and then you can start to move there. Then you can talk about the options to achieve that target and what those options are and where they stand, highlighting where the evidence falls and where we have outcomes data on certain medications and where outcomes data might still be pending and how that might, impact decision making. And so we are at time. I will skip this. This is a, sort of a very interesting slide where they're breaking up the coronary atherosclerosis based on the subclinical findings and using that to help to sort of guide therapy. It's a fundamental change in the approach. I studied under Matt Budoff, and this has kind of been really, has been hammering this concept of coronary calcification for risk scoring for the last 20 years. And it's nice to see it sort of come to fruition and make it to the primary guidelines at this stage. We'll skip about elevated lipoprotein A, and from there I will stop because we are at time. Thank you very much.
Thank you, Dr. Ronnie. I think it was a very interesting talk, and I think we're going to have lots of questions for you. But we'll move to the next speaker now, and then we'll have all the questions at the end. So, Professor Rosano, if you're with us, you can share your slides right now.
Yep.
Yeah, we see your slides.
Yeah, okay. And you can see me now. So I think Dr. Ronnie set up perfectly the stage for my presentation and how to use the guidelines, so on and so forth. And what I will discuss in the next 25, 30 minutes is how we can achieve lower LDL cholesterol. We've seen the data for the UAEs and on the cardiovascular mortality for as being the most important mortality in the UAE, but also that is true worldwide. And if we put heart disease as the leading cause, and if we put heart disease and stroke, they account for more than 50% of all the causes of death. What is important is that it's although we've seen in the past few years a plateau and or a reduction in mortality for MI, we've seen we're observing a projection to an increase in the prevalence of cardiovascular disease, but also stroke, and that is the same in all the ethnicities. You can see according to the different ethnicities, all ethnicities tend to have this progressive increase on cardiovascular disease. And we've heard from previous speaker that it's the event rates significantly increase after the first event, but you can see how that is very important for myocardial infarction that tends to increase progressively and continue, and as well as the cardiovascular death. But what is interesting is that if you look at the hypercholesterolemia in patients with hypercholesterolemia, after an event, there's both a similar increase in MI and stroke. And if you take patients with a previous MI, the increased risk of MI and stroke is the same. And this is something that is very, and it's really important and relevant. The event rate, of course, for an acute event increases significantly in the first year after a myocardial infarction. You see this is in the dotted line is for all patients. Of course, increases more in elderly compared to younger patients. This is probably because there's more aggressive risk factor management in these patients compared to the elderly. But it's not during the first or second year that there is an increased risk of a future event. You can see that the event rates increase even years after the indexed event. These are data from the REACH registry, where patients with a previous MI but without history of stroke or TIA were followed for 5 years. You can see that going from the second to the fourth year, already the event rates double. They go from 8% to 15%. So there is a continuous increased risk with doubling of the events every 2 or to 4 years. Now, we know that LDL is a very important modifiable risk factor for cardiovascular disease, and it's even more important for plaque progression and for cardiovascular events than all other risk factors. And just to give you an idea, if we take patients where we believe other factors are important, let's say take patients with diabetes, the UK PDS told us that in these patients is the LDL cholesterol and the HDL cholesterol are even more important than glycated hemoglobin. So in patients where the main problem is elevated glucose, still the LDL cholesterol is the most important risk factors for future cardiovascular events. So you see how strong is the LDL cholesterol penetrance and in these patients, and how it is necessary to reduce the LDL cholesterol as much as possible as the risk increased. And we've heard from Dr. Ronnie earlier how to assess the risk and how we need to be more aggressive with patients with a higher risk. Often we've been told, yes, we need to reduce the cholesterol, but how much the cholesterol? And we have to say that the levels that we are used to for normality that we use today, so 5.4 millimoles per liter or 200 milligrams per deciliter, are the values that are to which we've been accustomed, especially after the Second Industrial Revolution. Whilst before the 1800, the LDL cholesterol, the total cholesterol was around 2.8 millimoles per liter. You can also see how important are the changes in cholesterol after birth. You see that after birth, in those babies who are breastfed, the total cholesterol remains around 150, whilst in those who use a formula diet, and they tend to gain more weight, and as soon as they weaned, they tend to have this spike in the increase in cholesterol. This is something that is very important because we have to take we have to start our prevention in babies and children and adolescents in order to reduce the future occurrence of cardiovascular events. So we know that from the first decade of life, we start to have these fatty streaks. And then second decade, we tend to have intermediate lesions and atheroma. And the study that was conducted in the American military that died in Vietnam, they found already atheroma in young soldiers between the age of 20 and 30 at the autopsy. Of course, going forward, the plaques affect endothelial function, and by exposing the cap, then they might cause future cardiovascular events. But how fast is the increase in cardiovascular risk? You see that the exposure to cholesterol is very important, because in those without familiar hypercholesterolemia, the cardiovascular disease tends to be reached by the age of 55. Whilst in those with homozygosis of familiar hypercholesterolemia, then there is an increased risk already by the age of 12, so even before the puberty, and in those with heterozygous familiar hypercholesterolemia by the age of 35. Of course, then we've heard from our previous speaker the importance of early menopause. We see that in if we take a man and a woman with familiar hypercholesterolemia, the hypercholesterolemia time is moved 10 years in women. This is because of the protective effect of estrogens on the progression of atherosclerosis, given the same exposure to cholesterol. But when we look at the exposure to cholesterol, and we look at the different population with genetically lower LDL cholesterol, we see that the lower the cholesterol, the lower is the reduction in cardiovascular risk. And that mirrors the effect of pharmacological therapy. I won't go much into details in the atherosclerotic burden because our next speaker will discuss about it. But it's if we look at all studies or the studies that have been conducted with lipid-lowering therapy, starting with pravastatin and then going into atorvastatin, rosuvastatin, and more recently with the PCSK9 inhibitors, we see that we can reduce the progression of atherosclerosis. But if we want to have really a regression of atherosclerosis, we need to be well below the 70 milligrams per deciliter and probably below 50 milligrams per deciliter in order to have regression of a plaque. We know also that there is a linear relationship with lowering LDL cholesterol. So both in primary and secondary prevention, the lower the LDL cholesterol, the lower the risk of future events. This is true in primary and secondary prevention. And the absolute LDL lowering is related to risk reduction in cardiovascular events. This is both if we look at the major coronary events. So we see that if we reduce by 1 millimole per liter, so around 40 milligrams per deciliter, the LDL cholesterol. We see that over 5 years, there is a 23% major coronary events and a 20% reduction in major cardiovascular events. So looking at the progression, the regression of atherosclerosis, we can look at it in different ways, but you can clearly see that is around the LDL cholesterol of 50, where we have a significant negative change in plaque volume. So we need to aim in patients at very high risk to an LDL cholesterol level below 50 millimoles per liter. Now, we have heard from the previous speaker the importance of assessing the absolute cardiovascular risk, but what was very well presented in the ACC/AHA guidelines on dyslipidemia that were presented at the American College this year, is the fact that you can use this together with the assessment, the risk assessment based on age, sex, smoking, and all the risk factors that we have. We can use the CAG scan that we tend to use less in Europe, but also the carotid ultrasound. Because if we have a patient with, say, moderate risk, and then you find a plaque with carotid ultrasound on the carotids or on the peripheral arteries, then that reclassifies immediately the patient as a patient at high risk. If you have a high-risk patient, having a plaque will reclassify that patient at very high risk. So you see therefore that we can have an answer, risk analysis, and this can be the CAG scan or the presence of plaques assessed by ultrasound. Now, we know that we have many drugs to reduce cholesterol. We know that we need to use statins. We know that we need to use statins and ezetimibe. But if we look at the LDL goals, and these are they are infrequently achieved in patients, and especially in those patients at very high risk. And there's no difference between the different countries. You see, Middle East or Europe or the US or globally, there's over 30%, 70% of patients where the LDL cholesterol targets are not achieved. Now, there are different reasons for the failure to achieve the optimal LDL cholesterol. In some areas, there may be limited access to optimal care. In other patients, there may be difficulties with adherence, maybe related to cultural issues. There is an inability to tolerate optimal therapy. We have to say that this is over-exaggerated often, and because in clinical trials we find no more than 8% of patients that have to discontinue high-dose statins, and then also there is a genetic variability in the response. But look what happens if we change the statin regimen. So in patients that have a daily treatment and they go to intermittent, there is a 10% loss of benefit. If that is discontinued, you see that there is a significant 20% reduction in benefit. And we also know that after discontinuation, there is a significant increase in the risk of MI and in cardiovascular death. These are data for patients that had an early discontinuation. You see that after early discontinuation, there is this increase in patients who discontinue the statin therapy with a 26% increased risk for MI and an 18% risk in cardiovascular death. So there is patients who do take a statin and then they stop it, they tend to have an increased risk. And this is not just for the statins, it's true for all lipid lowering therapies. But now we are beyond the LDL, the statin treatment, and we know that there is another key, apart from the different enzymes that are involved in the LDL metabolism. There are also very important key players, and these key players are the LDL receptors. They capture the LDL particles on the surface of the hepatocytes. Then they bring it internally into lysosome and the proteins, and that get stored into the cell. And then the receptor gets recycled and reappears on the surface of the liver. So the more the LDL receptors, the more the internalization of the LDL, so the uptake of the LDL, and therefore lower LDL levels. But we know that apart from the LDL receptor is also degraded, and this is degraded by a protein that is called PCSK9 that binds the receptor, and after the receptor has released the cholesterol, then destroys the receptor. This leads to a reduction in the LDL receptor numbers and therefore an increase in cholesterol. Today, together, thanks to genetic engineering, it's been possible to produce an inhibitor of the PCSK9, and therefore this inhibitor blocks the degradation of the LDL receptor. So the LDL receptor goes and releases the LDL and then gets recycled on the surface of the hepatocytes. So basically what the PCSK9 inhibitors do, they basically bound with the PCSK9, inhibiting it, and therefore reducing the degradation of the LDL receptor. Now, of this, of course, we will be talking about evolocumab and the effect of evolocumab in the event trials, but you can see that the LDL, that evolocumab has demonstrated a very significant effect in reduction in cholesterol in patients with severe hypercholesterolemia in monotherapy, in patients who were statin treated, in patients on heterozygosis familial hypercholesterolemia, and in statin intolerance. You see that the degree of LDL reduction is the greatest in those patients who also take a statin, and this is why it's we always tend to, and all the guidelines say that the PCSK9 inhibitors have to be used in patients who are on statin. Whilst because in the statin intolerant, of course, we have a significant reduction, but it's not what we would like to see, like a 70% reduction. Now, this effect is the effect of evolocumab on reducing LDL cholesterol is completely independent of the type of statin, the strength of the statin, the statin ezetimibe combination. You can see that it's similar with atorvastatin 10 or 80, with rosuvastatin 5 or 40. And it's also in patients who take statin plus ezetimibe. This effect is constant and it's always very significant. I will skip all the mechanistic studies on plaque progression, and I want to focus on two outcome studies. The first is the Fourier study that included patients between the age of 40 and 85 years with a previous MI, stroke, or peripheral arterial disease with additional two risk factors. They were randomized to receive evolocumab or placebo. And as you can see, the treatment with evolocumab reduced by 15% the composite endpoint of cardiovascular death, MI, stroke, or hospitalizations for stable angina or coronary revascularization. But also, what is important, reduced by 20% the composite of cardiovascular death MI or stroke. So this is a landmark study because demonstrated that if you give PCSK9 inhibitors, if you give evolocumab on top of statin or statin and ezetimibe, you still have a further reduction, a 20% additional reduction in the composite endpoints. Now, when you look at the effect, you can see that the effect, the curves, as in all statin trials on the statin ezetimibe trials, they tend to diverge after the first year. And therefore, if you take those patients who already took the evolocumab for a year, you can see how this reduction in risk gets amplified. So you see that because the curves diverge even more. That is natural because you need to have a reduction in cholesterol. Of course, the initial reduction of cholesterol is important for the reduction in inflammation and the events that occur during the first year. But it is after the first year that there is a very important effect on plaque remodeling and reduction of future cardiovascular events. The effect of evolocumab, of the 20% reduction in the major cardiovascular events, was observed in all patients. But you can see that if you take patients with a recent myocardial infarction, so patients who had an infarction within the first year, this effect was even greater, was 25%, was 18% in patients with diabetes mellitus, but it was 30% in patients with multivessel disease. So if you have a patient with multivessel disease and with a previous event and on statin and ezetimibe, and you add evolocumab, you have a 30% reduction in future cardiovascular events. If you take patients with peripheral arterial disease, this is also amplified. The effect of evolocumab is amplified with a 27% reduction in cardiovascular events. And in those patients with more than two or more prior MIs, you see how the important evolocumab is very effective, and the effect in those patients at increased risk. So you see patients with PAD and patients with multiple events, it occurs much, much earlier. Then the Fourier-Oller study looked at what happens to patients who take or initially exposed to placebo and then they crossover to evolocumab. And basically, this is patients. They took all patients that were included in the Fourier study, and at the end, those patients who were on evolocumab were continued on evolocumab. Those patients who were on placebo were switched to evolocumab, and you see that the switch to evolocumab, the transition from placebo to evolocumab, reduced significantly as it did at the beginning of the study in those allocated to evolocumab, the LDL. Is that there was an effect on events in those patients who were on a placebo and then were started on evolocumab. But in those patients who were treated early, then you see how the event rates tend to be always lower. What does this tell us? It tells us a very simple very simple message, is that when you see and intercept a patient with increased risk, you need to treat them as soon as possible and very aggressively, because if you wait, then you still do get a significant benefit, but you lose the benefit of the initial treatment. That is true for MACE, but it's also true for cardiovascular death. As you can see in the effect in those patients who were on evolocumab and continued evolocumab over the years, the effect was there was a 23% reduction in future events. Now, but Fourier was conducted in patients with the previous event, so patients with a previous MI or patients with a previous stroke and or vascular event. Now, more recently, and this has been this data have been presented at the AHA in November last year. They looked at the effect of evolocumab in patients without a prior myocardial infarction or stroke. So patients with a lower degree of risk compared to those included in Fourier. And the study design was there were patients, stable patients with high risk cardiovascular events, but no prior myocardial infarction or stroke, with an LDL cholesterol greater than 90 and or a non-HDL cholesterol greater than 120. They were randomized to evolocumab or placebo. You see the classic effect of evolocumab in reducing LDL cholesterol by very, very significantly, bringing the LDL cholesterol below 50 milligrams per deciliter. And what did that treatment had as an effect? You can see there was a 25% reduction in the risk of cardiovascular with evolocumab compared to placebo, with the curves that started to diverge after 8-9 months. And if you look at the 4-point MACE, so that included also revascularization, then there was a 20% relative risk reduction. The reduction was very consistent. The risk reduction was very consistent, was always greater than 20%. So it was on the dual primary endpoint was similar. It was the same for MI, stroke or revascularization, or any combination of the primary endpoints, but also all the individual endpoints were significantly reduced. There was a 36% reduction of future MIs and a 30%, a 21% reduction in revascularization and 20% in all-cause death. The all-cause death is very important because it tells you how important is cholesterol in determining the future fate of patients with increased cardiovascular risk. And so it was a sound 20% reduction, not in cardiovascular death, but in death from any cause. And the benefit on the 3-point or 4-point MACE was similar in younger and older patients, in male and female, in patients with different degree of atherosclerosis, different baseline levels of LDL cholesterol, in those with high intensity statin, moderate low or low intensity statins, those who were not on statins, those who were on ezetimibe or no ezetimibe. So there was a clear benefit of evolocumab all across the board. So in a summary, I think I showed you that the magnitude of absolute LDL cholesterol lowering is associated with a significant reduction in cardiovascular events, reduction of atherosclerotic burden. As for today, we have not identified a lower limit of LDL cholesterol. I tend to see patients with an LDL of 25, 24. Now, what is they ask, should I reduce my medications? I say no, because the evidence is that the lower your cholesterol, the lower are the events. Now, we know that our decisions are supported by guidelines, that they universally recommend the statins as a first-line therapy. This is because they are cheap and they can be implemented in everyone. However, many patients do not achieve the LDL cholesterol goal, and despite the use of high intensity statins and ezetimibe, many patients are unable to control their LDL cholesterol, leaving therefore increased risk. And evolocumab has been shown to be extremely effective in reducing the risk of future events in patients with a previous myocardial infarction or stroke, but also in those patients with increased cardiovascular risk without a prior event and with LDL levels that we often see in clinical practice. And thank you very much for your attention.
Thank you, Professor Rosano, for the amazing talk. You definitely gave us lots of things to think about. So we'll move to our last speaker, Professor Mahmoud Abdelghani, and then all the panelists will join again for the questions.
Well, thank you very much for the presenter. That was excellent presentation, and I will build my talk on top of your presentation. So if you can give me a second here. Sorry. Okay. Okay, so my name is Mahmoud Abdelghani. I'm an intervention cardiologist and endovascular interventionist at Mediclinic City Hospital. And today I'll be talking about beyond LDL control to plaque regression. This is a disclaimer. So if we look at the prevalence of hyperlipidemia in United Arab Emirates, we'll find that the prevalence is really high. 72.5% of people in UAE have hyperlipidemia, out of which 38% have high LDL and 72% have high cholesterol ratio. And if we talk about the Middle East, this study shows that the majority of patients, up to 83%, were classified as being at very high risk of cardiovascular event, and 62% of all patients didn't really achieve the LDL target. So that was discussed by my previous colleagues, and you see in this slide, UAE is doing okay compared to our neighbors, but the prevalence of hyperlipidemia, according to the study you look at, is between 44 to 75%. That's much higher than our neighbors in Oman, 25%. But globally, we are more or less doing similar to global control. Why do we have a high prevalence of hyperlipidemia? That's because of multifactorial, so low adherence from the patient standpoint, and the clinical inertia to start medication and achieve an aggressive LDL control is not present. So all of us, including doctors and patients, have to do more work to achieve a better control over the hyperlipidemia. So as you all know, there are some modifiable and non-modifiable risk factors for cardiovascular disease. The non-modifiable risk factors include advanced age, certain races, and male sex. Genetically familiar hyperlipidemia, whether it's homogeneous or heterogeneous, and previous history of cardiovascular events. We cannot do anything for these, but what we can do is modify the modifiable risk factors. This include a better control over the hypertension, more exercise, eat healthy, stop smoking, and control your diabetes and lose weight. Most importantly, as the previous presenter showed, dyslipidemia is a major risk factor. So, and the most important risk factor, increased LDL level, increased LB little a, and decrease the HDL level. These are very important risk factors that we have to work very aggressively to control. If we see here, that's in the United States in patients with Medicare patients, which is a governmental organization in the US which takes care of patients more than 65 years old. What we can see here, this is 78,000 patients above 65 followed up for up to 10 years with a median follow-up of 3 years. We see that after acute myocardial infarction, there is an increased risk of having rehospitalization for coronary heart disease and increased risk of mortality. And in the first year following an MI, 10% experience another event, and out of these, 16% has more than two coronary heart disease rehospitalization. And that's why we have to be very aggressive from the beginning with patients with any event with ASCVD. This includes an MI, stroke, or significant peripheral vascular disease, because these patients, as my colleagues showed, that it significantly increased the risk of the patients to have another event. If we talk about the Gulf area, the secondary prevention is not well controlled. 75% of the secondary prevention patient did not achieve the target heart rate. Again, that's a multifactorial. From our standpoint as a healthcare provider, we have to be more aggressive controlling, prescribing the medication, making sure that the patient is taking the medication and adjusting the dose according to the follow-up. And from the patient standpoint, we have to talk to them very seriously about the importance of the adherence to the medication. And as the previous presenter showed, the adherence is very important. The more adherent the patient is, the lower chance the patient will develop another event. If we look here at the retrospective study to show the testing rate for post-MI, so this is patients who had an MI and come to outpatient to have a follow-up. In 3 months after an MI, you can imagine a patient had a major event of an MI. Only 27% of these patients were checked for an LDL level. Over 1 year, only 50% of these patients were checked for lipid profile. So as I said, from the healthcare provider standpoint, we have to, all of us, to do a better job and monitor these patients more closely. In this registry, which had 5,000 patients, 21% of the patients who had only one lipid profile in 2 years. So these patients had an ASCVD, they had an event, or they had major atherosclerosis in an imaging study. And in spite of that, in 2 years, these patients had only one lipid profile, 20% of them. So again, this highlights the importance of being aggressively controlling the LDL level, but also having a close monitoring of the lipid profile. This slide was discussed by my colleague, which basically shows that 48% of the patients in the Gulf area don't achieve the lipid target, and 68% in the Middle East don't achieve the target level. So again, this again and again highlights the importance of being aggressive with medication. So over 25 years of studies, starting with a Scandinavian study going through the TNT, Improve It, and Fourier trial, we understand that the lower the LDL level, the better the outcome, and we see that reflecting in the guidelines, decreasing the target LDL from 70 to 55, and even the ESC, when the patient has an extreme risk, to decrease LDL level below 40 milligram per deciliter. So the lower the better. How do we assess the risk? This slide was discussed in detail by Dr. Ronnie, and this is from the European Society of Cardiology. And more or less, the American College of Cardiology and European Society of Cardiology have similar or very close, recommendation. I would say the extreme risk that was not completely addressed by the American College of Cardiology. So the target of less than 40 milligram per deciliter, that's for patients who have polyvascular disease, like a coronary artery disease and peripheral vascular disease, or patient with ASCVD who experience another event in spite of maximum tolerated therapy. So even in this category of patients, we have to be more aggressive, targeting lower LDL level. Over years, we can see the difference between the 2019 guideline and 2026 guideline. So the 2019 recommended calculating the 10-year ASCVD score, but that was an older data, depending on older patient pool, and they have a higher cut point for the percentage upon which you start the medication, or you adjust the medication. So the newer Prevent ASCVD score basically removes the race from the risk calculator, consider the metabolic syndrome and chronic kidney disease in the risk calculator, and they have lower cut points to categorize the patients accordingly to low or borderline, intermediate, or high risk. So how to achieve an LDL level? This is from the ESC guideline. The first thing we need to ask, is the drug therapy indicated or not? And just to simplify that, and according to the ACC guideline, there are three major categories um, that needs to be on treatment. First category is patient with ASCVD. This includes an MI or any ACS MI, STEMI, non-STEMI, unstable angina. They have stroke. They have even finding on imaging of significant atherosclerosis. These patients should be started on statin therapy regardless of their number. Second category of patient is diabetic patient. A diabetic patient, especially when they have an end organ damage, they should be started on statin therapy, or if the LDL level above 190 milligram per deciliter. These three categories have to be started on a statin therapy. If not, then there are minor, other criteria. The calcium score, if it's more than 75 percentile for the age, or an absolute number of more than 100, we consider starting them on medication. If the CRP is high, or if they have evidence of peripheral vascular disease by ABI, non-invasive ankle brachial index. If not, you go and calculate the risk score, and accordingly, if you use the Prevent ASCVD or the older one, which I would not recommend using that, or you can use the score too. It's absolutely up to you which one you're gonna use and which guideline you will follow. I'm American trained, so I usually use the Prevent ASCVD score, and accordingly I start the patient on medication. So if there is no indication to start medication, so we recommend lifestyle modification. And if there is an indication for drug therapy, we still recommend lifestyle modification, but we add statin therapy. So if the statin therapy was enough, if the patient reaches the target heart rate, you should follow up the lipid profile. If not, you consider adding ezetimibe. And if the patient is not at goal, you add PCSK9 inhibitor drugs, basically monoclonal antibody or inclisiran. Both of them works absolutely fine. So for patients with an acute event or an ASCVD, like a STEMI, non-STEMI, stroke, unstable angina, I tend to start with a combination drug of a statin and ezetimibe from the start. Now we have one pill that has both medication together, so the patient end up taking one pill anyway, and the side effect of ezetimibe is not, very significant. So if the patient is at a very high risk, I start the combination medication from the start, and if the patient is not at goal, we add PCSK9 inhibitor medications. And why do I do that? As you can see here, if the patient is on statin therapy only, high intensity statin, there is about 50% reduction of the LDL level. If this is combined with ezetimibe, there is about 60% reduction. So, I try to get this 10% reduction more from ezetimibe from the beginning if the patient is at very high risk. Definitely, the combination of high intensity statin, ezetimibe, and PCSK9 inhibitor medication, whether it's a monoclonal antibody or RNA, like inclisiran, both of them would definitely decrease the LDL level furthermore when it's combined with the statin and ezetimibe. So if we look at the 2018 cluster guidelines, there was no mentioning of LB little a. In the 2026, this was addressed that patients with elevated LB little a who don't achieve the LDL level or non-HDL level they should be considered for PCSK9 inhibitors. We do not have a specific medication for the LB little a yet, but Amgen is coming with an injection that will be, I think, given every 3 months, and Novartis is coming with a medication that will be given every 2 weeks, and they are in the process of being approved. So having said that, the PCSK9 inhibitor and Repatha specifically in the Fourier trial was found to have between 20 to 30%, specifically somewhere around 27% reduction of the LP little a. Having said that, an isolated elevation of LB little a is not an indication to give the patient a PCSK9 inhibitor unless the patient didn't achieve the target LDL level. Again, in the 2018 cholesterol guidelines, there was mentioning of the PCSK9 inhibitor. It was pretty new at the time, and the guidelines, the medication takes some time to show in the guidelines. So in 2026, that was addressed in adults with ASCVD who are at very high risk on maximum tolerated statin and ezetimibe. On maximum tolerated statin, you should consider adding ezetimibe or PCSK9 if the patient didn't reach the target LDL level of less than 55 milligram per deciliter, or non-HDL, which is less than 85 milligram per deciliter. So we see that the newer guidelines are going deeper in depth, addressing the LB little a, addressing the newer medication like the PCSK9 inhibitors. So my presentation will talk, I'll try to concentrate now on the plaque morphology and vulnerability, and how the lipid-lowering therapy can affect that. As this was shown before, the LDL level reduce the endothelial nitric oxide synthase activity. The nitric oxide synthase basically cause vasodilatation, decrease the smooth muscle proliferation, and decrease the inflammation, and it decreases the platelet aggregation. So the LDL reduce all of that, and not only reduce the endothelial nitric oxide activity, but also it can cause oxidative damage by it increases the chances of having a superoxide synthase. A superoxide is a free radical which can cause an oxidative damage to the endothelial cells. So once you have an endothelial dysfunction, the fatty acid streaks start to form by an LDL and macrophages within the vessel wall, which form foam cells. The bigger the foam cells are, which contains the macrophage and lipid, the bigger the plaque is, and the plaque start to accumulate in the vessel wall. And then once there is a necrosis in the core of the plaque, necrosis of the foam cells in the core of the plaque, then this starts to be a vulnerable plaque. A vulnerable plaque has necrosis in the core, has a high lipid content, and a thin fibrous cap. And this predisposed to the rupture of the cap. And once there is a rupture of the cap, then there is an exposure to the tissue factors, which basically cause stimulation of the coagulation cascade and induce thrombus formation, which subsequently can cause acute events. And according to the acuity and the closure of the blood vessel, this can cause an ST elevation MI, or it can cause an acute limb ischemia, it can cause an acute stroke. If it's more gradual, it can cause a non-ST elevation MI, unstable angina, or can cause a critical limb ischemia, or wrist pain in the lower extremity. And if this happens gradually and it causes complete obstruction, that's when we see the chronic total occlusion of the blood vessel. So we have to differentiate between the stable plaque and the vulnerable plaque. A stable plaque has a small lipid core and a thick fibrous cap and more of a smooth muscles. The vulnerable or unstable plaque has a thin cap, and if you have a thin cap, there is a higher chance of rupture, and it has more lipid core, and it has increased macrophages and the foam cells. How to assess the atheromatous plaque? Uh, there are two ways to assess two different parts of the atheroma. The first part is we have to assess the volume of the atheroma, how big is the atheromatous plaque, and to assess the stability of the atheromatous plaque. The IVUS is intravascular ultrasound is very good in assessing the volume of the plaque. If we see the image on the left labeled A, and down there is a magnification. So this layer inside, which what we call a lumen surface, is the endothelial layer. The second layer here is the internal elastic membrane, and the layer there is the external elastic membrane or lamina. So the distance between the lumen surface or the endothelial surface and the internal elastic membrane, that's where the plaque forms. And this is what we see here in the IVUS. So the image A is a normal IVUS, while image B you see here with the magnification, this is the endothelial layer, and far there is an internal elastic membrane, and the in between, which is this area, that's the plaque. So the IVUS is pretty good in assessing the plaque volume, but the OCT is better in assessing the characteristic of the plaque, the cap, the lipid arc. So the OCT, which is optical coherence tomography, was produced in 1991 in MIT, Massachusetts Institute of Technology. Basically, it produces high-resolution cross-sectional images of the arterial wall by measuring the near-infrared light intensity reflecting from the tissue. So what we mainly concentrate with the OCT here is the fibrous cap thickening and the lipid arc. And if the thickness of the fibrous cap is less than 65 micrometer, this suggests a thin fibrous cap, which is associated with vulnerable plaque and increase the risk of plaque rupture. And if the lipid arc is big, wider than 90 degrees, this also suggests increased lipid content, which also increase the chances of plaque rupture and make it a vulnerable plaque. How did Repatha affect the plaque in the coronary arteries? So the GLAGOV randomized clinical trial was an IVUS-guided randomized clinical trial. Basically, this trial had almost 1,000 patients, 968 patients randomized between two arms, the arm of having Repatha and the other arm was a placebo. Each arm had 480 patients, and these patients were followed up to 76 weeks. And at the 76 week, the patient was re-imaged again to see the plaque burden. So let's look here the change from the baseline. So all of these patients were on maximum tolerated statin therapy, and on top of that, they either received a placebo or Repatha. So the percent atheroma volume was minimally affected in placebo, but there was a significant decrease with Repatha. The total volume was significantly decreased by Repatha, and the percentage of patients who had regression of the atheroma volume was much higher in Repatha compared to placebo. So probably 20, 25 years ago, we used to tell the patients, if you have a plaque, it will never get smaller. What we hope for is to stabilize the plaque or decrease the progression of the plaque. So if you have a 30% blockage in the coronary artery, taking a medication, we hope that the 30% stays 30%, or it takes 5 to 10 years to become 70% or more. So with aggressive medical therapy, including even statin therapy, so Dr. Steve Nason from Cleveland Clinic, Ohio, in 2006 showed in the trial that even an aggressive statin therapy in the ASTEROID trial was associated with a regression of the plaque volume. The PRECISE trial in 2015 showed that adding ezetimibe even furthermore decreased the plaque volume. And then in 2016, this trial shows a PCSK9 inhibitor further more and more decrease the atheroma volume. So an aggressive medical therapy with lipid lowering medication, whether this is a high intensity statin or adding ezetimibe or adding PCSK9 inhibitors, can decrease the plaque volume. So we can now tell the patient, if you have a 20% stenosis, this can, with aggressive medical therapy, decrease to 10% stenosis. I'm not sure it can go to 0%, but we have an objective evidence that we can achieve some regression of the plaque in the coronary arteries and peripheral arteries. And this, again, in this trial, we show that the lower the LDL level, the plaque volume decrease. So with a higher LDL level, there is an increase in the plaque volume. So if we talk about the OCT, and as I explained before, the OCT shows a higher resolution imaging, and we can have more details from the OCT. So in the image labeled A, you can see the CAB, the fibrous CAB, and you can measure the thickness of the fibrous CAB. In image B, you can see this yellow dots are actually the macrophages. So you can even see the density of the macrophages in the CAB and the lipid core. In image C, you can see the thrombus very clearly. And in image D, you can see the new vascularization or microcirculation, which if it happens, it can increase the chances of rupture and make the plaque more vulnerable to rupture. Image E, for example, it shows rupture of the CAB, which is the arrow here, and it shows that the lipid core, some activities in the lipid core of the plaque here. In this study, which was published in 2021 in JACC, they studied the STEMI patients and what are the risk for what did they see in STEMI patients? They see that 100% of them had high lipid plaque. 97% of them have thin CAB fibroatheroma, which is less than 65 micron, new vascularization or microcirculation, remodeling. All of these are risk factors to make the plaque a vulnerable plaque. And even they studied where can the plaque being vulnerable, and it was different according to the arteries. So for the LAD, the left anterior descending artery, it was very close to the ostium, close to the in the proximal segment. In the LCX was also in the proximal segment, but in the RCA there were two peaks or two areas that tend to have higher plaque burden, which is the proximal RCA and the mid RCA. So this study studied the was an OCT study in patients taking placebo versus Repatha, and this study was meant to study the thickness of the fibrous CAB and the lipid core and how the Repatha can affect that. This study has nothing to do with correlation between the fibrous CAB thickening and lipid arc and the chances of cardiovascular event. We know the chances of this was established by other studies, but this was purely meant to study the effect of the Repatha on the cap thickness and the lipid arc. So in this study, they studied they enrolled 160 patients, 80 in each arm. These patients had non-STEMI. So basically, this was in the non-culprit artery. So if the patient had a non-STEMI, they fix the culprit artery, but they look at the non-culprit artery, and if the artery has more than 20% stenosis, they would enroll the patient. What did we find? Oh, the primary and secondary outcome, basically, as I mentioned, they were looking at the cap thickness, the fibrous cap thickness at 50 week, as well as the lipid arc. The baseline characteristic between both arms were more or less similar. Most of them were males, almost 70% of them, and they were using a statin in almost, in average, 95% of the patients were on a statin. About 80% of them were on high-intensity statin. The baseline OCT measurement was similar between both groups. The minimum cap thickness was around 55, and the maximum lipid arc was almost 225 degree. So basically, it was well randomized, and both arms have similar characterization. So what did we find? We find that Repatha increased the cap thickness by there was an increase of 42.7 micrometer, while the placebo increased it by 21, and there was a reduction in the lipid arc by 57 degree with the Repatha compared to 30 degree with placebo. So the addition of Repatha to maximum statin therapy nearly doubled the absolute change in the minimum fibrous cap thickness and greatly reduced the maximum lipid arc compared to maximum tolerated statin therapy only. And we find that only 12% of patients in the Repatha arm had at least one image with a minimum fibrous cap thickness of less than 65, while 30% of the patient on placebo had that. So basically, this tells us that Repatha was effective in increasing the thickness of the fibrous cap, which makes it more stable, and decreasing the lipid arc, which also makes the plaque more stable. And this is an image from the study itself. As you can see here, that was before treatment. The upper images are before treatment, and the lower images are after treatment. So the thickness of the cap here increased after the treatment with Repatha, which makes the plaque more stable, and the lipid arc decreased with Repatha, which also decreased the chances of rupture and make it more stable. In this study, there was 80% reduction of the LDL level compared to placebo. And again, this correlation, the lower the LDL level, the more the thickness of the fibrous cap, which makes it more stable cap. That was also proven to be safe. The Repatha in this study proven to be safe, and there was no significant difference in the rate of death, non-fatal MI, myalgia, or discontinuation of the medication. So in this trial, the Repatha was safe and tolerable by the patient. So in conclusion, to conclude, the vulnerable plaque is characterized by thin fibrous cap and large lipid core, and the exposure to increased LDL level and continuous inflammation makes the fibrous cap more vulnerable and increase the chances of thinning of the cap and subsequently rupture. And intensifying the lipid-lowering therapy by maximum tolerated statin plus ezetimibe plus Repatha after ECS can help the patient getting a lower LDL level and subsequently stabilize the plaque. And if the patient with coronary artery disease and maximum tolerated statin therapy, adding Repatha improved the plaque stability, improved the outcome, But the last trial I showed again was not meant to show the correlation between the fibrous gap and the cardiovascular event. But again, that was established by other trials. At the end, what I'm trying to say here is as following: the lower the LDL level, the better the outcome. With the three presentation you just hear, there are a lot of data that support that. So all of us have to be more aggressive with the lipid lowering therapy, whatever it is, and trying to emphasize to the patients the importance of taking medication and being adherent to it, because adherence is basically half of the treatment. The more the patient is adherent to the medication, the better the outcome. And with this, I would conclude my presentation. Thank you very much.
Thank you, Professor Mahmoud, and for the insightful talk. Now we'll have all our speakers joining us for the question and answer. And there is lots of questions coming up. And as I suspected, Dr. Ronnie, you're getting the majority of them.
No, it's for everybody, really.
Yeah, well, yeah, we're gonna address them all together. I think that would be more useful. But it's always like as I like whenever there's a dyslipidemia talk, I tell everybody for cardiologists it's very easy, go as low as possible. But for primary prevention, it's a little bit more tricky, and it's sometimes complicated and not easy to address. So one of the questions was about which risk calculator to use, because we don't have our own risk calculator. There is the SCORE2 calculator from the ASC, and there's the PREVENT calculator from the ACC. So which one do the speakers think is more relevant to the Gulf area and would be more useful in our population, basically? Maybe you can start, Dr. Roni, and then we go to Dr. Rosano, and then Dr. Mahmoud. You can all weigh in into this.
It's well, thank you very much. I think I mean, the short answer is it's unclear. What would be the quote best calculator? And the reality is there's probably not a best calculator, and it probably just sort of depends on the patient that's sitting in front of you. I sometimes will, my typical go-to is the SCORE2, and the reason is because it at least takes regional variation into consideration in regards to what country you're from or what region of the world you're from, and sort of classifies you. So I like that's built in there. Admittedly, I haven't used the PREVENT risk calculator enough to get a feel for it, to give any sort of personal feedback about it, except to say that, look, you get a little bit more of a wider range. You're getting, I think, down to the age of 30, if I'm not mistaken. And they have eliminated race from it with the idea that will sort of normalize the information, irrespective of where they're coming from. But the reality is the data is still built out of the US on a lot of it. I think race is a big part of it, but also lifestyle, exposure. There's a lot of different factors that play in that I think don't get captured in these risk calculators. One of them might be simply sort of a culture of exercise and sort of dietary sort of, awareness. I think is slightly higher in the United States, specifically in specific parts of the country where you're going to have a lot of elevated awareness that you may or may not have in other parts. So I think you have to look at the patient in front of you, which is why sometimes, you're really sort of grabbing at everything you have to make that decision. I don't know what everybody else thinks.
Professor Rosano, do you have anything to add to it? Yeah.
I agree with Dr. Roni. I tend to prefer maybe the SCORE2 for the same very reasons that he highlighted. The fact that, I mean, we are living and working in a multicultural society, so we need to apply the score to the patient we have in front of us rather than using one score. Probably the other reason would be in your region, the use of the SCORE2 with a correction for non-HDL, for HDL levels. And because that is very important. I mean, your besides cholesterol, there is a residual cardiovascular risk in the region given by non-HDL cholesterol, the elevated triglycerides, and low HDL that is captured better by the score too.
Dr. Mahmoud, do you have anything to
Yeah,
comment?
so I tend to use the Prevent ASCVD score. Yeah, I was trained in US. I just came from US, so that's what I used to use. I think the Prevent ASCVD score overcome the problems that we had in the 10-year the traditional ASCVD score. First of all, it has a wider range of age. So it started at 30 years old, while the other started at a higher age. It eliminated the race, and it considered the chronic kidney disease and the metabolic syndrome. Also, the 10-year ASCVD score, it had a tendency to overestimate the risk. And according to the older population, or no, the data we had, but now with the newer data and the Prevent ASCVD score, we have a better estimation than the older score to assess the risk. I think it really doesn't really matter too much which score you are going to use, as far as you are going to treat, the patient and put the patient on the appropriate therapy. At the end of the day, both of them are very, very close and very similar to each other.
So, I mean, I kind of agree with Dr. Rani and Professor Rosano that the score, given that it gives some emphasis into high risk countries, so then you can do some risk estimation related to the Gulf area. But none of this, as you, Dr. Rani said, none of this was built for us. There is a score that was done for the UAE, that was done in a small population in Abu Dhabi, and it hasn't been validated overall the UAE. So that's something that's worth looking into it. And I think you guys know from our previous talks that Dr. Wael Mohammed has looked into the scores, but that was previously, so not to score 2 and not to prevent, but the previous scores. And at that time, like there was poor correlation with all the scores, but the QRISK score from UK was the closest in estimating risk in the UAE. So what I usually
I
do in
would
the
say that the Prevent ASCVD score, maybe the only extra things that it gives over the score two is the 30-year risk score, that is not provided by any of the European Society of Cardiology scoring system, but it is provided. It gives the 10-year score and the 30-year score. So I would say it's a little bit of a plus.
Okay, so if I can finish what I was just saying. So usually what I do in practice is I would do the QRISK score because it was the closest to us, and then I would do one other score. So I would do 2, and then I see what I get. But I think what Dr. Roney said in his presentation is very important when he said you have to make sure that the clinical diseases are not there and then do the score, because that's a problem also when you just look at someone who fulfills a high risk and then you just go and do the score. You need to, once they're they're high risk, there's no need to do the score anymore. So I think that was very interesting.
And also, I think it's important to add the risk modifiers like the vascular ultrasound or the coronary calcification, because those you can calculate the score, but then you can refine it and reclassify patients at a higher risk just by using a very simple test like a vascular ultrasound.
So there's a couple of questions addressing this. So maybe we'll move. So we're gonna have you, Professor Rosano, answer first for this question, but we're gonna hear from everybody. So the question, let's just pick the one about risk modifiers because you just mentioned it. So he's talking, and it was actually addressed to you as well. So about high sensitivity CRP, when should it be measured and how many times should it be measured? So, some guidelines say twice, some guidelines say once. And do you know if statin will reduce high sensitivity CRP? And what would you do when you have it elevated? Do you think that the new therapy that's still ongoing for Roselti will have greater clinical outcomes? So give us like your 5 cents on high sensitivity CRP.
Yeah, of course, we need to see the results of the ziltivekimab study. because if that be, I mean, very positive, then it will give more weight on the measurement of CRP. Although in the ziltivekimab study, they measured only CRP and not IL-6, which is the target of ziltivekimab. Well, once we'll have that, we'll have a clear answer. I mean, the UK biobank study demonstrated that there are independent risk factors, but the CRP doesn't add much unless it's very elevated. So it is good if you have if you want to use resources. I think that probably if you have to choose, and depends on the costs, on the availability, on your clinical setting, if you want to refine your score, you can either go on imaging or you can go on a biomarker. And all of them add some more information. We don't know exactly how much the CRP then will add into your score. Of course, identifies patients where you want to have a lower target for treatment, as it does the vascular ultrasound. So I think we need to use it wisely and not do it in everyone. Do it at least once. But again, if you do it once, then it may be affected by the fact that there's been a previous event or the patient is unstable. So it is the eye sensitive CRP is not absolute, and even if you measure twice, it can differ according to the inflammation status of that moment in that patient.
Yeah, Dr. Ronnie, do you have any comments about high sensitivity CRP?
Nothing major to add. I use it as a decision maker. If the decision hasn't been made. So I agree with Dr. Rosano. So if you've already sort of committed to putting them on therapy and everybody's on the same page, I don't necessarily use that. If they're coming in and it's part of a sort of a primary prevention screening, and along with carotid ultrasound, or if you're going to be doing calcium score, if it makes sense, then it will get bundled into that, and then it's just another element that's being used to either upgrade or downgrade the patient's risk, in my mind.
And measure it once or twice? Or
look, if they're primary prevention and the decision was not to put them on therapy, and then you're seeing them again a year later, I'll measure it again, see if things change. I mean, I find these things, I have a reasonable pool of patients that refuse, any lipid lowering therapy. I'm sure we all do. And for those that really are sort of dedicated to getting themselves healthier and taking a sort of a lifestyle approach, you'd be surprised. You can actually see that CRP shift when they really get serious about their lifestyle. So it does move the needle. So, it's all dependent on the patient in front of me.
Dr. Mahmoud?
Well, I agree with Dr. Rosanna and Dr. Ronnie. I mean, it's an add-on element, so it can, probably emphasize your decision to start the patient on lipid-lowering therapy. Measure it once or twice. It depends, if 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 I measure it the first time and it's within normal limits, then I am in the gray zone of starting the patient on a statin therapy. I would consider rechecking it. But again, being affected by the inflammatory status of the patient put some limitation on it too.
Okay. And anyone uses colchicine for someone with elevated high sensitivity CRP?
Not as a primary prevention. I mean, it's
secondary, yeah, I've done it.
Yeah, it's secondary prevention. So generally, if someone with established CAD and you're worried about a new event and they have a elevated high sensitivity CRP, then yes, low dose colchicine.
Yeah, or even if they don't, honestly, if they're recurrent events coming in and you've sort of maxed out everything else, I'll add it.
Okay, very good. So then to the next risk modifier, LP little a. So does the measurement of LP little a affect your decision to start a PCSK9 inhibitor, for example? And in what setting, a primary prevention or a secondary prevention? So you wanted to go first, Dr. Mahmoud?
Yeah, sure. So The LB little a, as I think Dr. Rizana showed it, the higher the number, the significant increased risk of coronary artery disease and ASCVD event. Having said that, still we do not have, until this second, we don't have a specific medication to target LB little a. PCSK9 inhibitors in the Repassa in the Fourier trial was associated with a decrease of 20 to 30% of LB little a. What we are facing here in UAE is the approval by the insurance, you know. So I don't think you can justify just by the LB little a, an elevated LB little a to start the patient on PCSK9 inhibitor. Statin therapy does not significantly affect the LB little a, or in some studies it can increase it up to 5 to 20%. So, and that's where we are limited, and that's why we are looking forward for the newer medication is specifically targeting LB little a, and subsequently, hopefully, the insurance would look for that. But if I can put one way or another, the patient on PCSK9 inhibitors who have an elevated LB little a, I would do that. I would try to get the 20 to 30% reduction of the LB little a. It is a very significant risk. It has a very significant risk to increase cardiovascular disease for sure.
Anything else to add? Yeah.
Maybe without the evidence of drugs specifically targeting LP-Lillet, I wouldn't spend much money. I mean, it's you can do it. The European guidelines suggest to do it once in your life, although that is not entirely correct. Because, for example, we know that in women post-menopause, there is an increase up to 9-fold in the next 10 years. So that is probably something that's been just extrapolated from men and doesn't take into account women and menopause. So that is something we still have to learn, and we have to see if the drugs will be positive, and which subsets, which patients, how often to measure. At the present, if as Dr. Rodney said, is part of a large panel, that it's in the assessment of primary prevention, maybe measure it, but otherwise, I don't know, maybe spend those money on something else. I'm sorry, we live in a social sort of socialized care where we have to be careful about what we spend. And so money comes always into consideration.
But it does change your target, right? So if you have someone who's high risk, and then the LP little a is very high, then it's going to move to a very high risk patient, right? So you're going to do, and probably when you do that shift, you're going to need to use a PCSK9 inhibitor. So you're going to get it, you know, a benefit both ways. Of course, it's not studied specifically for this, but you know that you're going to get this 30% reduction when you do that. Any comments, Dr. Ronnie?
No, I think you know, I agree overall with what everybody's saying. It's I think the short answer is we're lucky that we're going to have data very soon. So I think that's going to be very, very helpful. And to me, it's helpful because the patients that are coming in with primary prevention that are otherwise low risk, but the only signal they have is a high LP little a. You know, I mean, if everything else fits fine, I think because the fact that we're getting data soon, I may not sort of just start grabbing at random medications with the hope that we're going to reduce risk because we have information. You know, if we were 5 years ago, it might be a little bit of a different story just because we're stuck. The other part I would say is, I think, you know, the number influences me, you know. So, I mean, if their LP little a is 120, 150, yes, that's elevated. But, you know, the percent, you know, if you look at the fold increase, right, as we saw, you know, it's not, yes, there's a certain percentage that's elevated. But when you start to get to 200, 300, 400 on your nanomoles per liter, then that risk multiplier really starts to shoot up. And those patients are the ones that really, really worry me. I mean, I don't know if I have any patients with LPAs in the 400 that do not already have cardiovascular disease. I mean, it's almost, you know, I don't think I've even seen one. It might be a selection bias just because of the way the clinic is. But, you know, so, and just the one thing, you know, when you looked at the sub study, and I think it was the Fourier trial, there was a signal that they got a little bit more absolute risk reduction by being on the PCSK9 inhibitor. Was that because there's something specific about the PCSK9 inhibitor, or did they just their higher risk category, and then by lowering their LDL more dramatically, they just had a benefit of the risk? So I think either way, it comes back to the same thing. If they're high risk, you're going to put them on medicine, and like you said, Dr. Zueda, you know, look, if you're 40% away from your target, it's going to make sense to go to a PCSK9 as your second medication, anyways. And you take that 30% reduction and hope it's making a difference, but I don't know if we know.
We're gonna know in a couple of years, I guess.
Yeah.
When
Well, we
the
should supposedly at the end of this year we should have data. So
let's hope for the best.
let's hope one way or the other we'll know.
So another question for you, Dr. Shahrouk. So patients with subclinical atherosclerosis. So this is another problematic issue. So especially in our population when they're young, and then they have multiple risk factors, they're diabetic, but no ASCVD event. How do you manage someone in that population? And so that was the question. But I also like from your slides, the last slide when you showed the calcium score and with the higher calcium score, does that even apply to us, our population? Our population, they're all young. There's lots of non-calcified plaques. So
It's
comment
yeah,
on this. Yeah.
it's a tough one. I mean, again, I think the ACC/AHA, they're trying to really sort of break down the data as best as possible. And it sometimes creates a little bit of confusion, I think. But look, I'm always shocked at the amount of underlying, subclinical, if you want to call it, we'll call it subclinical. They have, plaque, that the plaque burden is extremely high for the region. I uh, didn't expect this when I've been here now 7 years, and I'm always shocked. I came from the US where you would never even think twice about ordering a calcium score in somebody that's below the age of 40. And now it's like I can't find a patient whose calcium score is not zero between the ages of 30 and 40. And so it's changed the practice a little bit for me, admittedly. So look, I think you have to judge what it is. I mean, what I'd like to think about is, look, what should the patient have at that particular moment in time? So, I mean, if they're a 35-year-old, I mean, by all means, this patient should have a calcium score of 0. They should have no plaque. I mean, this is absolutely what's expected for that age group. So if you get a score of 10, that still bothers me in somebody that's between the ages of, let's say, I don't know, 30 and 35 or 40. If I got a score of 10 in a 70-year-old, I'm not even sure they need medication, at that point. They've already passed. So I think you always sort of have to judge that. Again, if they got multiple high risk features, they're a diabetic and they don't have anything else, but now you have a calcium score that's, even if it's mildly elevated, then that worries me. They're already laying down plaque, they're already forming things. It gets trickier. I mean, I've had patients who, walk in with a CT angio and they got calcium score of 0, but then there's soft plaque everywhere. And then, you can go that extra mile, you can go do a clearly analysis on it, and it can be high risk plaque. And then you scratch your head and say, well, it's high risk plaque. I'm going to put them on medication. The nice thing is you can always have the discussion with the patients. And we're lucky that at least with multiple classes of medications, LDL reduction, there's no bottom. It's not like blood pressure where these patients are going to start passing out and falling. So, I have that discussion and I say, look, you don't meet criteria for guidelines, but if your goal is absolutely to have the lowest risk cardiovascular wise event, then we do have some evidence to suggest maybe going on medicines is reasonable approach. You have plaque, you're young, and look, your risks are, the mild, you explain it, whether it's, myalgias or glucose risk and things like that. But other than that, we've got what, 40, 50 years of data now at this point, at least showing, from overall these are safe medicines, however you slice it. Yes, there's a lot of stuff that you can argue about that, it's not perfect. And but that's in the bigger picture, they do a fantastic job, right?
So we have lots of other questions, but I think we ran out of time. So I'd like to thank you all the wonderful speakers for staying up until this time and answering all these tricky questions and giving amazing talks for everybody. And I would like to thank the audience for staying until the end. For the CME, you're going to receive a survey through the email that you registered through. And after you answer the survey, you're going to receive the CME certificate within 2 weeks. And thank you, everybody. And I wish you a wonderful night. And yes, and for the people who asked about the high sensitivity CRP, we have a webinar tomorrow, especially about inflammation in the heart. So don't miss it. So thank you, everybody, and take care. Good night.
Okay. Bye.